morning, everyone. Good morning to our audience via YouTube live stream. And good morning to all our commissioners. Welcome to our February GIC meeting. And hope everyone is having a great day. We do have a new commissioner, and so I am thrilled to welcome Gersino Garon. He is from Boston. He tells us that Boston is still vibrant and busy, so I'm looking forward to a meeting in Boston live to see all of you very soon. But until then, let's all be safe. So welcome, Gersino. I know Matt's going to give you a few minutes to say hello, but I also welcome you to say hello right now to the commission and to our constituents watching from YouTube and live stream.
Good morning, everyone. My name is Gersino Garon, and talked to a few of you before, Matt and Ms. Sullivan, and I'm so happy to be here.
No, we're thrilled to have you too. So welcome. And
Thank
I know
you.
the entire commission and the staff are very excited to have you on, and will help you on board and be as active on the commission as you like to be. So at this point, I will entertain a motion by roll call to approve the minutes of our meeting in January. Do I
I'll
have a
second.
motion?
Yeah.
Okay.
I say motion.
Okay, great. Any discussion? All right, then, Andrew, I will hand it over to you for roll call. Yay on my part.
Vice Chair Kaplan,
Yay.
Designee Roder,
Yay.
Designee Butler,
Yay.
Commissioner Shabbat,
Yay.
Commissioner Chapdelaine,
Yes.
Commissioner Choate,
Yes.
Commissioner Culinard,
Yes.
Commissioner Davis,
Yes.
Commissioner Garon,
Yes.
Commissioner Edmonds,
I think that was a yes.
we just lost you on, yeah, we lost you on mute, okay. Commissioner Gentile,
Yes.
Commissioner Jennings,
Yes.
Commissioner Murphy Rodriguez,
Yes.
Commissioner Sinenko,
Yes.
and Commissioner Timothy Sullivan.
Yes.
The motion passes unanimously.
That's terrific. Okay, well, if there's no other business as we open up this meeting, I'm going to pass it over to Matt.
Thank you, Madam Chair. We can go to the agenda slide. There you go. Thank you. Welcome, everyone. Thank you, Madam Chair. Welcome, Commissioner Garon. Really excited to have you on the commission. As you noted, we had the opportunity to speak last week, and I was really excited to learn about some of your life experiences that you can bring to the commission, particularly your experiences as a direct provider of care to folks with intellectual disabilities. So thank you for joining us. We're thrilled to have you. So here's a look at our agenda. I'll just say a couple of brief things about it. The executive director's report, you will note we're doing a little bit differently this meeting so as to economize our time in the meeting. So you have received, each of you, a written executive director's report. There are a few items here that I will speak to verbally that are not addressed in the report. So rather than go through that, I will just note the items that are, address the items that aren't in the report and field any questions. We are also picking up our prior short discussions on race and ethnicity data. I'm really excited to update the commission about all the work that is underway in this area. I'll be joined by Margaret Anschutz on that presentation. Deputy Executive Director Erica Schiavelli will report out on our public information sessions, which we held 4 of 2 weeks ago. Again, really excited to report the level of participation, which was just through the roof. We will also spend some more time on the out-of-pocket report. We will review some of the ground, not all of the ground that we covered at the last meeting, as we were pressed for time. And I want to make sure that we give commissioners sufficient time to ask the questions that they have. And then we will complete the 2 slides that we did not get to on behavioral health and pharmacy. And then we'll close out with a vote on the 1 recommended plan design we discussed in January. So that's what we have set up for today. Next slide. So just a quick headline of the director's report, and I'll go to the calendar next. Next slide. So you'll see in the red box here where we are today at today's meeting. The next few meetings, we have a little bit more bandwidth to take up some additional items as we get the kind of busy season of preparation for annual enrollment, at least at the commission level behind us. In March, you'll see we have the final vote on plan rates. I'm also going to take the opportunity of that meeting to provide a bit of a look back at my first year, where we will at that point be just about at the 1-year mark for me. So I want to bring back to you some of my learnings, observations, and developing plans looking forward. I also expect at that meeting to be able to provide at least a draft of our commission agendas through the end of the calendar year. I want to be able to give a sense of where we're headed, not just over the next few meetings, but looking forward. So there are a few moving parts, and I'll be working with the commission leadership to make sure that we populate these coming several meetings with agendas that we can manage. There are a few things that I will note that we're trying to find the right slot for here. We have the interesting possibility of having an expert on vaccine hesitancy to present to us, someone with a clinical background from one of our vendors, where I think that would be really timely if we can arrange for that to be done in March. So we're trying to make schedules work for that. I also want to find time before we get to the end of our fiscal year meetings this year to start to do some deeper dives on our key cost drivers. And we'll probably be looking to do that, spreading that over the April and May meetings, if not June. In May, you'll see here, we're coming back to continue the discussion. We'll kind of launch in earnest today about diversity, equity, and inclusion more broadly, not just the race and ethnicity data. And in June, we'll have, we will then be on the other side of annual enrollment, so we'll be able to report out on that. We have a few other items that we'll be taking up there. I will note we're likely going to have David Seltz from the Health Policy Commission and Ray Campbell from CHIA join us in June to report out, as they have in the past, on their annual cost trends report. So that's a little sense of calendar and where we're headed. Next slide. So again, here, I will rely for these matters mostly on the written report. I do just want to touch on one item and then have my colleagues touch on briefly on a couple of items. So under COVID-19, I want to just talk a little bit about how the ongoing pandemic is impacting our move, our office move. So just a reminder, we are moving to 1 Ashburton Place. That timing was all accelerated as part of COVID. We are one of the pilot agencies as part of this rethinking of the work environment. Very exciting to us. So there's a lot of work ongoing here, but we've also wanted to make sure that we conduct this move mindful of two things. One, how it's going to impact our ability to perform during annual enrollment, which is coming up very soon. So we want to minimize any disruptions to our ability to manage that. But also, it's really challenging to think about how we can, in this environment with COVID where it is right now, have people into the office to do the kind of document review. What documents do we need to move? What can we keep but digitize? What can we throw away? So there's a number of work streams that we're really having to adjust here. So it's leading to a little bit of a longer timeline for us to actually say that we've moved. Probably in June is our best guess at this point. So I want to just give a little update on that. I am feeling really good about the move. As I said, Maureen Quinn on our team has been superb managing that with a handful of other members of the senior team. So with that, I will hand it over to Jim Rust, our CFO, to touch briefly on the year-to-date budget performance. Jim?
Thanks, Matt. We don't have our usual slides today for a couple of reasons. It's a little bit early in the month for us to have closed in time. So I'll just give you a verbal update as to where we are. As of last month, we were showing the bottom line to be about 97 million favorable to budget. This month, we spent a little bit more than $8 million more than we anticipated for the month, which is within the realm of our normal volatility. So to date, through January, we're about $91 million favorable to budget at the bottom line. Do you want me to go through the COVID spending real quick as well, Matt?
Maybe just a brief highlight of it,
Okay.
That it, the rise in those claims continues.
Sure. So I think in your packet you have the COVID chart, so I won't read it to you, but it's interesting to see kind of the post-holiday surge that we've read about in the news, and we've all been experiencing at the hospital level. We've seen it in the claims now. Monthly claims for COVID were about $16 million in January. That's up from $14 million in December. And as a comparison, over the summer and early fall, they were about $8 to $9 million. So overall, we've spent in FY21 $81 million. And overall, over the two fiscal years, FY20 and FY21, we've spent about $124 million on COVID claims. Any questions on that? Okay, thank you.
And the last update here will be for Denise, a very brief update on the health benefit consultant procurement.
Good morning, everyone. Yes, thank you, Matt. Yes, we have received 5 full bids, 1 bid only on the prescription drug consulting, and are in the process of evaluating those bids. We are aiming to present our recommendation of the apparent successful bidder or bidders to the commission at the April meeting, and targeting the May meeting for a vote.
Thank you, Denise. So that will conclude the executive director's report. I'm happy to pause here if folks have questions on the items we've addressed or any of the material in the executive director's report. Toby has a question.
Matt, I noticed under the EAP program an impressive open rate of 24.5%. That's great. Any insight to why you're seeing that spike? And that was around financial wellness, the email open rate.
Yeah, I don't know if Linnea Walsh from the team who manages our EAP is, I think she's on, and if she has anything that she'd like to offer for that.
Linnea isn't on right now, Matt. I think she's got some PTO today, but I would say that around the financial wellness part, we don't have any insight kind of data-wise, but I would say anecdotally, it makes a lot of sense as to why right now folks would be more interested in looking into financial wellness given what's going on around us. But I'd be happy to chat with Linnea and see if we can get some more hard data to come back to you with.
Thank you.
Sure.
Thanks, Erica. Further comments or questions on the director's report? if this format continues to work, please let me know, or if it doesn't work, please let me know. Providing the written report ahead of time.
Yeah,
Seems to
no,
make sense.
Matt, I like it, but I also think the balance of you given a headline on it is helpful to all commissioners as well as our constituents. So, so thank you for evolving the way we're managing these commission meetings. It's good leadership. Thank you.
Thank you.
Matt, I can't find my little hand to raise, so I don't know what I'm doing. I'm waving, so I apologize. But I just wanted to say that I really appreciate receiving the written version of your report beforehand, because as I'm sure everyone knows by now, for me, sometimes there isn't enough time for me to ask questions when I get the report in advance. Probably going to be helpful to everyone if I have my questions ready. But I really appreciate it because it's very helpful to me, and I'm sure it's helpful to many other commissioners as well. But I just wanted to make one comment regarding the calendar. This is the same comment I make every single year, is that we have one meeting regarding to discuss and vote on the rates. And that's always disturbing to me because we have two meetings for plan design, right? We have discussion and then we have a vote. And we have two meetings to talk about the consultants, right? Typically it's presented and then the next meeting we vote. We do not do that with the rates. And so there's no time to discuss and to really have a substantive discussion and then vote. We have to do it in one meeting in 2 hours. And even though we, sort of spend the entire meeting talking about the rates, that never sits well with me. So I just wanted to say it now. I'll probably say it again next month because I find that annoying, and I recognize it has a lot to do with procurement, but I just wanted to get that on the record once again for the first time this year.
Thank you, Madam Vice Chair. That's helpful feedback. I will note that while you are correct that it's the first time we will see detailed rates by carrier in that March meeting, but we do have the prior meeting, which I'm looking at my calendar, back in December, where we did bring preliminary aggregate average increases, and that is what we have at that stage in the process. We don't even today yet have finalized rates by carrier. This is work that we spend a good deal of time on with the actuaries at Willis Towers Watson. But I appreciate the feedback, and we'll see where we can improve.
Yeah, and I don't want you to think,
excuse me, Bobby, if I could say something. So
sure.
Potentially the carriers may be listening to what Bobby is mentioning, because it's their workflow, it's their way of doing business that is really the comment that Bobby's addressing. And so potentially our partner carriers can take notice of Bobby's concern. I'm going to go to Christy. She's had her hand up for a while. Hey, Christy.
Thanks, Valerie. I just wanted to ask just for someone to talk a little bit about under legislation, under the fiscal year 22 budget. Do I understand that correct? That the overall Commonwealth budget has a decrease in spending, yet the GIC item actually increases by 4.5%. Am I reading that right?
I defer to Jim. That's my understanding, but I defer to Jim Rust, the CFO.
I don't know about the Commonwealth's overall. Do you mean the whole Commonwealth Belgium for the whole state? I'm not as familiar with where they ended up on that. I could certainly look into that, but our spending went up by about that amount, correct?
Yeah, so that was Christy, you are correct. The overall budget is what is referred to there in the earlier part of that sentence, but it's so we were trying to give it overall context with the rest of the budget, but that's our piece of it is the part that's increasing.
Oh, thanks, Christy, for bringing that up. Liz, you had your hand up and now it's down. Is there anything that you have a question on or comments?
No, Valerie, it wasn't a question. I just want to reiterate what Bobby has felt. I think we've talked about that, and there should be more time to discuss rates, the questions why, some kind of explanations. That's all.
Okay.
Thank you.
Okay. Yep. No, I think the carriers hopefully are listening and can certainly support us in that comment. So thank you. So Matt, I don't see any other discussion, so we can move on and stay on budget, not budget, agenda, but we are talking budget. So
yep.
Money's always top of mind for all of us at this commission. So that time is just as valuable.
Yeah, just one last point on those comments. So this, as I said, I'll just be completing the full 1 year cycle here. So this will have, give me the advantage of having seen everything that we do over the course of a year. And I'll use that experience and that learning and the feedback I'm getting from you all to see how we can adjust that to meet your needs going forward. So thank you for the feedback.
Great.
All right, I think we're done with Executive Director's report. All right, so this section, Margaret Anschutz and I will be presenting on race and ethnicity data. If we can go to the next slide, please. So this, of course, is a very important topic that has unfortunately gotten squeezed out of some prior meetings. So I apologize for that. So we wanted to make sure that we place discussions about race and ethnicity data right at the top of this agenda and dedicate some real time to it. And before we get into that specific issue, I thought it might be helpful to just widen the lens a little bit and put that specific data question in a broader context. And I think it's important to start by stating it plainly that there is inequity in our healthcare system in Massachusetts and across the country. It's largely based on racial and ethnic lines, and it is longstanding and pernicious and is perpetuated by structures of institutional racism. We don't have to look too far for clear examples of that. Recent news about how COVID has impacted Black and Brown communities are the most recent example of that, but there are so many others. And Margaret, in her presentation, will touch on a few of those. But these are also not new. These are long-standing inequities in the healthcare system. So our obligation, and we really have an opportunity at the GIC to do our part to really dismantle these structures that support this inequity. We can do so as an employer of an organization with 72 staff through recruitment efforts, different strategies of recruitment efforts, career advancement within the organization. We have a very diverse staff and we need to keep them and promote them, but there's certainly more work for us to do there. I look forward to coming back at a future meeting and talking in more detail about that, but that work is already underway. But also, just as the largest payer of insurance in the Commonwealth, we understand and we need to understand better how we can close the gaps in these racial disparities. And part of that is to enrich our understanding of the impact of a broad range of social determinants of health, and gathering data on that and how those dynamics impact our members disproportionately and differently is the critical first step. The good news, as I note here at the bottom, is that it really feels like we're at an inflection point, largely driven by the events of the past year. There are a number of complex legal questions and challenges that we have to work out, and we owe it to our members to be as transparent about how we use this sort of data as we can possibly be, and how we're using it and not using it. I think that's important. But there's also a broad coalition that is emerging here that understands that we need to figure this out. I wanted to just start with that kind of broader lens before we dive into some of the more detailed data questions. I think that's what I wanted to say there, and on to the next slide, a couple more slides for me before I hand it over to Margaret. So just illustrating this growing kind of groundswell, I would call it, to take on this data question. The Attorney General's office released a report in the fall that acknowledged the lack of this data broadly across the healthcare system, not just payers, also providers. And I think the key here is the healthcare system, as we know, is very fragmented. And we need to develop strategies for standards of that data so that we make sure that we're developing a data set that doesn't simply reflect the fragmentation of the healthcare system. So I think the top item here as a recommendation from the Attorney General's office is a really important one that's going to take some time and attention and real collaboration with other parties. Next slide. So here also, this is a slide we borrowed from the Health Policy Commission. They made last summer, they made health equity a top priority for the agency. And what's exciting about that to me is that they can bring their unique strength in data analytics to help ensure that the data we do collect is the type that we can actually use to drive changes and addressing the social determinants of health. I'll note in bullet number 1 here, again, the important concept of developing standardized data collection requirements. So with this growing group of entities, we want to make sure that we're all developing our approach to this in a way that gives us a usable resource to drive change to close these health disparities. That was the primary takeaway I wanted to highlight from this slide. So with that, I want to turn it over to Margaret to do a little bit, to go a little bit deeper on the data collection efforts. What I want to emphasize here is that we're not standing still, we're not waiting. This is work that has been ongoing on multiple fronts, and we're going to take many opportunities over the course of the year to keep you updated on our progress. I'll turn it over to Margaret.
Thanks, Matt. So next slide, please. Great. In my next few slides, I'm going to walk through first the current state of race ethnicity data collection broadly in our health system, the steps that we're taking at the GIC to collect race ethnicity data, the policy goals that we're building toward, and our next steps. But before I speak more about the data, I want to take a step back and emphasize that this is not fundamentally a data collection project that we're embarking upon. This is in fact a reducing health disparities project, the first step of which is to collect the data. So I don't want that goal of eliminating health disparities to get lost in the conversation about where we are with collecting the data. So turning to the first bullet point, the current state of race ethnicity data collection, where we are and why we're there. It's important to understand that this problem is systemic. So I'm going to discuss this data first in the context of our health system. And as Matt mentioned, and we're all aware, the health system that we operate in is deeply fragmented, with multiple stakeholders operating on and in multiple systems, only some of which overlap, and when they overlap, it's only sometimes. So to be a bit more concrete about that, on the provider side, we see medical records providers work in. They're hosted by a variety of different vendors that are often incompatible. And these records' primary function is to hold health information such as diagnoses, treatments, doctor's notes, prescriptions, that kind of information. These medical records are separate and distinct from our insurer's claims data systems, which was constructed primarily for the purpose of payment. And as for public entities like the Department of Public Health, for example, they have immunization records and death records, but these data are also collected for their own purposes, and the data doesn't always really talk to other data sources or data systems. Much like medical records and claims data systems, they are built for their own specific purposes without the expectation of sharing or compatibility across these different systems. So as a grim but concrete example here, the CDC can report on maternal mortality by race ethnicity, which we'll see later in this presentation, because they have access to death certificate data where race ethnicity is present. That's not in the claims data, it's largely not in medical records, although of course there are exceptions. So we can't measure health disparities anyway, excuse me, the stakeholders have these separate data silos, but you may ask, what's keeping all of them from collecting this race ethnicity data? In short, the answer is a lack of standardization of the fields and definition of data. We can't measure the health disparities if we haven't had an industry-wide standard for measurement. For example, in some reporting systems, respondents have a check all that apply option around a set of options such as white, Black, Hispanic, Asian, Native American, whereas other reporting systems allow only one answer. Still others allow people to self-identify by writing in their response. This leaves industry stakeholders in a bit of a bind as they can implement their own standards. They can have their own set of options to check, and some have, but their measurements will not be directly comparable to others if they're not working from the same definitions. And that's the key to standardization and the key to establishing comparable metrics across stakeholders.
Hey, Margaret.
Yes.
Is there a way though that, let's not let perfect be the enemy of good.
And that's how I'm going to bring this home.
Good. I hope so.
Absolutely. I wanted to set out where the problems have historically been.
No, I know. I just want to make sure, that to me, it sounds a little bit like an excuse.
Yes.
Rather than, making it so like, okay, if it's, somebody says Black, but somebody says African-American, can we just have some sort of way to look directionally? So
the short answer to that excellent question is, I know how to solve for this. We know how to solve.
Good.
It's going to take time, but we can. And while it's taking time, we have methods to impute, but I'm getting ahead of myself. But I think the point you're making is critical. And I think where we are right now, what we've been missing in the last 20 years has been really the groundswell that we're seeing now, the importance of coming together to build consensus on what these standards are. And that's where we are. So I wanted to give you a sense of historically.
No, and I appreciate that. And I'm sorry I jumped in and stole the number.
May I jump in, Madam Chair, for a minute?
Yeah, sure. Go ahead, Jane.
As I listen to Margaret, my take is that I'm delighted that she's giving us this foundation because it's the first time that I've seen us have a real focused conversation on this topic, which admittedly is complex and would take every bit of our brain power to figure out ways to resolve. And I think it's critically important for this conversation that this commission does spend time looking at 3 different chunks. And that includes where we have been. And that's what Margaret's doing, kind of give us a sense of what has gone on historically. And then where we are now, you know, what's happening at the moment. And we certainly know some of the implications of the systemic racism that affects this country and the air we breathe. But then we have to think about where we're going. And so I think that this is a great start. I mean, I'm very, very encouraged by the leadership that Matt displayed in his opening comments and by the granular detail that Margaret's giving us. So I'd urge us all to be a little patient.
Thank you. Thank you. So that's an overview of why this data is not widely available and some of the complexities in building a system that is inclusive of all of the providers, of all of the members of the public agencies, and ultimately the goal there is to be inclusive of all members of our population. The healthcare system, this is part of a rebuild of the healthcare system that is much more inclusive of the patients it serves. So as I was saying, and to use Matt's words, there is a groundswell around an urgency around collecting this data. And so these conversations are happening, the conversations around standardization. We see it at the federal level, and we also see it statewide. Matt spoke about the Health Policies Commission, their role in leading efforts around data standardization. We are at that table too. We are working with our sister agencies and with our health plan partners to discuss and build this standardized reporting definitions that can be used across the state, so that really once we have this data, we are in a position where we can collectively measure health disparities and intervene to close that gap. Next slide, please. Okay, so that's the history, where this conversation has been and where we're headed. You know, we're at the table around the discussion about standardization, but we're not, there's some work we can do in parallel to these conversations, and these 3 bullet points represent our plan for gathering this data. So while we are discussing the standards, we're also exploring the possibility of collecting data from employers where it's available. In parallel to that, we are also imputing membership, race, ethnicity, and this is a bit technical, but I'm in the data warehouse build that we have currently going on. I'm pulling in census tract data with race, ethnicity information, so we'll be able to look sort of with broad strokes at race, ethnicity in our membership. I also expect to bring in a more sophisticated algorithm to impute race, ethnicity while we're working on collecting data. But really the gold standard is self-reported data, and employers have that, and so do, and we'll have the ability to collect the self-reported data through my GIC link portal. The vision is that when members log in, they will have an option, a pop-up box or something built into the architecture there where they can self-report their race, ethnicity. I want to note on the bullet, the first bullet, collect from employers where available. This is a pretty complicated conversation where our members have reported their race ethnicity to their employer with the expectation that that was just for federal reporting purposes. And it's tricky legally, and we're not quite sure that it would be appropriate to sort of pull in data that was not gathered for this explicit purpose. So we're currently kind of having those conversations.
So I'd like to, Margaret, I just wanted to, first of all, thank you, because I always appreciate the history. Like Jane, that's very, very important to know and understand the history before we're able to move forward. But regarding the My GIC link, yes. Although self-reporting will be of great importance, I think that some explanation, right? When subscribers, right, when the employees log into My GIC, because if we do not provide, you know, the right description and explain the direction in which we are headed, then people will not self-report because they will be suspect, right? They'll be suspicious because of prior history, right? So, and, you know, those of us who work in state government also know the Commonwealth collects race and ethnicity data.
Yep.
For hiring purposes, for promotional purposes. That information, I don't know, you know, where it is specifically located, but that information is collected and has been for a long time. And, you know, whether we are, you know, legally able to use it, I don't know the answer to that, but that's also, I mean, they have a huge data collection of that. So, because they also have to report to the feds. So I just wanted to mention that. It's not like we don't have the data, but my guess is it's pretty fragmented.
Thank you for your comments there. So taking the first comment about self-reported data and the need to explain to our members why we're collecting it, I am very aware of the fact that collecting the data is also kind of a public affairs campaign that has to go alongside with it, not just at the individual member level, but also any employers we want to work with. So we're developing a stakeholder plan alongside the data collection plan, where we plan on reaching out to, you know, having talking points, excuse me, talking points for our public information unit, reaching out to members with explanations. And I expect that public affairs campaign will be just as robust as the data collection campaign. To your second point about employer data, yes, I think all of the points you raised are right on, and it's a matter of you know, being respectful of the fact that the data was collected for a specific purpose. The people who it was collected from understood that it was going to the specific purpose, and being sensitive about, you know, if someone didn't expect their data would be used in another way, you know, there's some gray areas there. So we are working through those conversations right now with employers. Next slide, please. Okay, back to the purpose of this data collection. Here, our goal, as stated on the slide, is to eliminate health disparities in our membership. And this graphic here shows the maternal mortality rate across race and ethnicity, and it should be startling. This illustrates the gross disparity in the Black and Native American maternal mortality rates compared to the general population. And note that this is after controlling for other social determinants of health, such as income and education. So this is about race. And this is just one of many health disparities that have been documented for decades. So looking at this, this is a screamingly urgent project. More Black women are dying after childbirth, and Native American women are dying after childbirth than any other cohort. We first, in our population, need to collect our data, but then there's no doubt in my mind that we're going to see health disparities in our population as well. So we'll bring the data in, that's step one. Step two is to do the research and see in our population where are our specific gross health disparities. And then step three, which is really the ultimate aim here, eliminate these disparities.
Yeah.
Next slide.
Well, you know, Margaret, I just want to pause and
please
express that, you know, to me, I'm really sad by these numbers. I know there's not a lot of deaths and, you know, total, but one death as a result of, you know, post childbirth is just too many, because in today's healthcare, you know, it should be easy, you know, quote unquote, easy to eliminate, right? But it's not. And then when you see the gap, it just makes me sad and very motivated to try to figure out, you know, how can we get people to self-report so that we can look at this data, you know, and eliminate the skepticism and get the, you know, society and the people who might be hesitant to help us, because we all want to do the right thing. I mean, at least that's how I feel right now with this data. And I've known about it. I've been in healthcare my whole career. You know, I remember, you know, in my early career at Pfizer, you know, this is going back a long time. I don't want to make myself sound older than I need to sound. But, you know, we talked about, you know, health literacy, and we did all these campaigns. And to think that there are still problems and to see it so starkly, I just want, you know, anybody who's listening, but certainly people of color, to know that I want to join forces and do everything I can to help. And I know this commission does. I know Matt as our leader does. I know our state government, as you know, Governor Baker leads our organization. We all want to do what we can. And we need some help, though, with the reporting. But we also just want people to know, or at least I want people to know, that I care and want to be part of the solution.
Yeah. Thank you for that. And I think I would add to that it's really an indictment of our health system, and we need to dismantle the structures that are present.
And I hear it in your voice that this is hard for you as a data person to see this data. So thank you for taking that on. And Jane, I know you have your hand up, so I'm not ignoring you.
No, I know you're not. You never do, Madam Chairman, and I appreciate your remarks. And I too can hear it in Margaret's voice. This is tough stuff. And I would just add that in addition to sadness, it is an indictment for all of society, because I hope that this one slide just drives home the message that we should be more than sad. We should recognize that this one chart shows that racism, if we have to give a definition of racism, it is vulnerability to premature death. That's what it is. It's human beings who are losing their lives. And it hasn't happened in the last 2 years or 10 years. It's happened for 400 years. So, I mean, the fact that that you talk about an inflection point, we have an opportunity. So one of my questions will be, and I won't say anything more because I don't want to dominate the discussion, but I will be asking respectfully to Matt, going back to his very strong leadership opening, how will the GIC hold itself accountable, and how will we as commissioners know that we are making progress, however incrementally?
Yeah. Well, I think that probably requires a little bit more thought. And I know Matt is thinking about this, but I think it's a good point, is what are the metrics, both, short term, medium term, and long term. And I do think, Jane, that because I know Matt is committed to it. I also know Margaret is a really good data analyst and can figure out a way to get us some metrics to show that we're committed and making progress.
Absolutely. And I tell you, I came to data through my heart, and this is an issue that strikes at the center of my heart. And I have been looking into quality metrics and metrics that point to health disparities by race, ethnicity. And I think there's fertile ground for us, once we get the data in, to really partner with with the carriers very closely on reducing the outcomes particularly for health outcomes along race and ethnicity. That's where I see us going.
So I have a question, Margaret. I don't know if you're the right person, or if this is more directed, toward Matt, or something we can certainly find out. But I'm very curious as to knowing, first of all, that the U.S. has, doesn't rate very high in healthcare, period. And we have known about these disparities, maybe not, to this extent, but we all know about these disparities in certainly infant mortality and maternal mortality for Black and Brown people, because those, the data's been around for quite some time, years and years. We know it. But I'm very curious what our healthcare providers, each of the six, have done, knowing as far as maternal and infant mortality. What programs have they implemented? What have they done, let's say to date? What have they done in the last 5 years? I'm very curious, because I don't know, past childbearing age, and not that I'm not interested in that, but it may not be, it is sort of on top of my list, but I haven't looked at it. I don't even know. And I would be very curious what our healthcare providers, not the providers, but the plans have done to help to, if not eliminate, to mitigate some of those issues, as far as prenatal care, intervention. How do they work with the individual providers? Like, what have they done? Because that might help us when we're talking about providers, when we get to the next procurement. That might be something that we want to put in our, RFR.
Yeah, no, Bobby, what a great what a great comment. I think that's great. So I'm sure the procurement team will pick up on that.
If I may just go ahead.
Adam has his hand up, and I just don't want to ignore him.
Madam Chair, if it pleases you, maybe Matt should respond to Bobby, and then I can jump in after that. Is that okay?
Yeah, I just had a very brief comment, which is that we actually, with Margaret's leadership, working with Denise Donnelly, did do a survey. We took the opportunity, an opportunity that we had to survey our carriers about a wide variety of issues in this category, including measures, programs, initiatives, care management programs that specifically address the social determinants of health. So that for us was kind of a baseline exercise to understand where they are today. But we will be doing a good deal more to understand and to prod and to push to do more.
Thank you.
Thanks, Matt. And thanks, Bobby. And thanks, Adam. So now Adam, please, and then I do see Anna has her hand up as well.
Thank you, Madam Chair. I'll be very brief. I wanted to jump in first to say thanks to Jane for making sure that this stayed on the radar of the commission over the past several meetings and even longer. I want to thank Matt for really clearly stepping into a leadership role and addressing these issues, and thank Margaret for clearly rolling up her sleeves to really dig into this work. And I think there's direct evidence that this work has been going on for a while internally, and now we're getting to the point where the staff is ready to report out and start this discussion with the commission. But I think I want to share that in my organization here in Arlington, we've been doing a lot of work on issues of race and equity, and we've brought in a team from the National League of Cities to help us understand how as an organization we can best prepare to address issues of systemic racism. And the model that they've helped us put in place is one of starting with normalizing the existence of the issues of systemic racism so that everybody on the team has a common understanding of the past and the present and how we got here. Moving to organizing so that everybody on the team can start to think about how we can do what we need to do and plan to do what we need to do to start dismantling the systems that have created these disparities. And then moving into operationalizing, where you're actually doing the dismantling and improving outcomes based on that normalization and that organization that help you move into the operationalizing it. So I'm really happy to see that. I think, you know, today as a commission, we're starting the normalizing. In terms of staff, it seems like they've already moved past normalizing and they're in the organization phase. And I think I want to say that as a commissioner, I want to do everything I can to help as we move from that organization phase into the operationalizing phase, so that we can really start to have an impact from the point of view of the commission. So thank you.
Wow, that's great, Adam. I like that. So thank you. So go ahead.
Very
Ann.
well said. I just wanted to throw that. Very well said, Adam.
Yeah.
Thank
Nice.
you. Great. Yeah, I agree, Adam. Excellent comment. And I just wanted to add just 2 points. One is how, well, I really want to first say that I think this is such an important issue. And so I think it's really, really good to see both the staff and the commission sort of take it, express that similar view. So I think that's a huge thing. I'd like to thank Matt and Margaret for all of their work. I think it's so great to see you guys coordinating across the other agencies and efforts in the state, and that there's sort of these two components going on, both a short-term and a long-term program at the same time, so that we don't have to wait a really long time to start to address these issues, but we also are building towards a better future at the same time in terms of how we're measuring and identifying where the GIC could potentially intervene to better serve our members. And I think that the carriers, you already mentioned working with the carriers about intervening, and I think also the data collection piece, the more you can work with the carriers on that, the better as well, because they're already supplying the claims data. And so the extent to which the carriers also recognize the importance of collecting these data on the claims would be, I think, make this job a little bit easier for you all. And then the last point I was just going to say is that, to Adam's point about bringing in support to do this work, I think the question is, and Margaret is doing just an excellent job, but if she needs support to do some of the imputation work early on, so we don't have to wait to address this, I mean, I think as a commission, we should think about how we can support Margaret and her efforts to really measure the disparities, identify where we want to intervene early. And so it's not all, so because she seems to be doing an incredible job on her own, or not completely on her own, but I know she's bearing the brunt of all of this. And so it may be the place where some expertise on how to do this data work would be helpful.
If I could just say one thing in response to one of Anna's comments about working with the carriers. So we've had we had a really terrific call with a combined Tufts and Harvard Pilgrim team specifically on this question. Juan Lepera from Tufts Health Plan is someone who's very engaged in this data work. So not only are we coordinating from them, we're learning from them, and they're learning from us. So I suspect as we do more of that with the rest of the carriers, we're going to find similarly. So I was very encouraged by some of that initial engagement.
All right, I think, Margaret, you've got the floor back to keep walking us through this presentation you've put together. So thank you.
All right, let's move to the next slide, please. So this is resources for the commission. You know, as everybody knows, the health disparities are not limited to maternal mortality. They are gross and across the system. So just here's a few more links sponsored by the Center for Disease Control and Prevention, specific to diabetes, hypertension, and what we've seen with COVID recently. Next slide. Okay, and here's our next step for our stakeholders and standards. As discussed at the top of the presentation, we are working with our sister state agencies to establish standards, while also, as Matt just mentioned, meeting with the carriers to collaborate on data collection, standards, potential population interventions. And I'm happy to take any more questions.
Thank you, Margaret. I just want a terrific presentation.
Thank you, Commissioner.
Thank you.
Go ahead, Jane.
I just wanted to say I have so much gratitude, and Margaret, excellent. Thank you so much, Matt. I appreciate all of you, all of my commissioners that took this time and that we had a good discussion. And so let's get moving to the next step, and I look forward to what we can do together.
Yeah. Yeah, I can assure you, Jane, that Matt is very committed to it. And so I know on our conversations, he is thinking about it. And I think your comment on, you know, what are the measurements, short, medium, and long, I think we need to come back and put a stake in the ground and start working towards that, because it can be an overwhelming job. And so, you know, let's manage to how we can show progress and not let perfection be the end game, but progress. Along with others. So that's not the only one. So thanks for the thumbs up, Jane. And then I see Cassandra, you have your hand up. So go ahead, please. You have the floor.
Thank you. I just want to echo everything that everyone has said and thank Matt and Margaret for all the good work that they're doing here. Also, I just wanted to note that I've read the AGO Health Equity Report, and I think everything that's been discussed here certainly aligns with what's been said in that report and what the HPC has discussed on this topic as well. I know that one recommendation in the AGO report is potentially to launch a health equity hearing at some point within the Commonwealth, and I think that would be a great opportunity for the GIC to continue engaging with the HPC, the AGO, and other agencies that are working towards improving data collection and better understanding and eradicating health disparities in this area. So I think there's great opportunity for progress to be made, and I appreciate everything that the GIC is doing.
Yeah, no, nice, Cassandra. Thanks for that comment. All right.
I don't know if Jane has another comment. Her hand is still up, but she may just not have brought it down.
It's down now. So thank you, Jane. And thank you to all of the commissioners and to the staff for this conversation. That's not a one and done. And I can speak for you, Matt.
Yeah, it's superb feedback. So thank you. And I hope it's apparent. It sounds like it's apparent, but this is an issue that resonates deeply with the senior team here. and deeply and personally. This will be a priority, and we welcome and accept the challenge of holding ourselves accountable and being accountable to you for progress. All right, I think that wraps that part of the session. Thank you, everyone. Terrific discussion to be continued. For the next item, I'm going to turn it over to Erica Shabelli, our Deputy Executive Director, to do a brief readout on our public information sessions. Erica.
Good morning. Thanks, Matt. Thank you, Madam Chair. We can jump to the next slide. So as you know, we had 4 sessions over 4 days for public information sessions about the upcoming annual enrollment, and just giving folks a heads up really on plan design and an opportunity to ask questions and to learn more about the GIC and our procurement processes. So this slide here is just a really quick by the numbers, and the 4 sessions that we had ran just over 6 hours. We had a few sessions that went a little long, which is great. And we had 9 commissioners who attended across those 4 sessions. So thank you for your participation. As you can see, we had an excellent response in terms of registration, and that's the 4,390 registrants across all 4 sessions. So that's just a massive, massive number, and we were really thrilled by the response that we got. And that's in no small part due to the kind of communication efforts that were put in place in advance of the session. So you can see we sent over 200,000 postcards to save the date to subscribers. We've found with the guidance of the commission that getting kind of hard copy information into folks' hands via the mail has been really helpful. So we went that route. We got really great responses out of that. And we also did a number of email blasts in addition to social media and with the help also of our commissioners. So thank you to each of you for kind of pulling in your networks on that and letting your folks know that these were going to be happening. As expected, only about half of the registrants actually attended. That's pretty normal. So we weren't surprised by that. But even with just about half attendance rate, the number was still fantastic. So we were really excited about the engagement that we got there. Within that, we had 467 questions asked in the live events. That number doesn't include the questions and comments that we received in our email. So that's just in the live events. And we had 9 members of staff online to answer those questions both live in the Zoom Q&A function, so you could answer real time in writing, or to answer those questions live over the feed. So a good number of staff on board, ready and prepared to answer those questions. So like I mentioned, we did get 467 questions. There's no way we could have answered all of those in the time that we had allotted. And not to mention that a number of them had pretty specific and sometimes personal information in the questions that were being asked. So we've directed those individuals with more personal related questions to contact us directly, or we were able to triage those questions in real time and get folks answers right away without having that their personal information subject to kind of publication. So we were really careful about that. And lastly, with the questions that we received and the comment that we received both in email and during the live events, we're compiling at the moment actually a thorough frequently asked questions document that we will go ahead and publish on the website, as well as sharing specifically with all the folks who registered for the information sessions. So we're currently working on that. We have, as noted in your materials, there were about 15 questions that were easily pulled to the top. We've compiled those already, and now we're taking a second look at some of the questions that weren't as popular, I guess you could say, but still wanting to make sure that we get those questions answered. So you can click to the next slide, please. On the topic of questions, these 6 themes were the common themes that we saw in terms of questions being asked. I'd say with retirement being the most popular. Thank you to Paul Murphy, who did a really great job in kind of quickly pivoting and ended up giving a presentation all his own and for the last 3 sessions, which was really helpful and helped us address a lot of the questions that were coming in. So you can see here those 6 themes, and we'll make sure to break those out in our FAQ document so that they're kind of categorized and easy for folks to find. But that, we had a really, really good time doing it. It was actually really fun. And it was exciting to engage with members and get them the information that they needed. And we got really great feedback from members immediately after. So we were really thrilled by that.
Hey, Erica. Yeah, I had a nice time from the comfort of my home doing the listening session. So I wonder, do we have a % increase from this year to last year in terms of participation, given that, people could join from the comfort of their homes?
So I would say anecdotally, given I wasn't here last year, anecdotally, I'd say yes. And I think Matt can probably speak more to that. But from what I've been told about sessions past, there would be pretty good attendance at some of the kind of more centrally located events, like in Boston, but that it wasn't as well attended in other locations further outside the city. And doing it virtually has allowed for much greater participation, like you said, from the comfort of someone's own home, especially when you're looking at dates in January that are cold and often snowy.
No, I loved it. And I guess it was a leading question because I think it's got to be like 1,000% increase, just knowing, years past going to the Cape and having, even when there were contentious meetings, I don't think the Cape had any more than maybe 70 participants. And I just wonder, can we keep this up? Can we keep doing it? How many people are viewing it? And, if we want to engage our constituents, maybe to share data, like we were talking about in our last one, can we use these type of virtual meetings to engage our membership and get the support we need? So I'll just leave it. Yeah.
I think Commissioner Kaplan has her hand up.
Thank you, Erica. I agree with our chair that this is the way to go. These virtual sessions, whether we decide in the future to have any physical ones at all, or maybe some hybrid, but I think this will, first of all, save the commission money. It's much more cost effective. It's less time consuming because it eliminates the drive back and forth. And we obviously have greater participation, which is the most important thing. And I was very curious which sessions, whether the evening sessions were more popular, or was it like the Saturday morning? I'm very curious, so that going forward, we might double up on the ones that were more popular.
Sure. So the second session, which I believe was a Wednesday, occurred at lunchtime, and that was at your suggestion, Vice Chair Kaplan, and that was the most popular, the lunchtime session. We had, if I recall, I think I actually had my notes scribbled over here. We had over 2,000 registrants just for that session. So that was by far the most popular. The Tuesday evening session, which was at 5:30, was behind that in second place with about half as many registrants. Then the Thursday evening session was behind that, actually tied with the Saturday morning session, which were right about, I want to say just under 300 for each session. So by far, the most popular was the lunchtime session on that Wednesday.
Thank you very much. So we probably should at least add on another, at least one more lunch session, I would think, but that's terrific. That's great. Thank you very much. Thanks.
No problem. And if there are any other questions, I'd be happy to take them, but that's what we've aside from the report that you received in your materials.
Hey, Tim, I see you have your hand up. Go ahead.
I attended the Tuesday evening session. I thought it was well done. Kudos for when we ran into some technical difficulties there. At the end, the staff picked right up. I thought that was great. The one thing I did think was important, I know Bobby had mentioned the noontime meetings, but when you're dealing with the educational component, teachers can't get there at that particular time because their lunches are usually 20 minutes or so. And so that would not be an option for them. So, and I have stated for years and years that we needed those evening meetings. So thank you, number one, for making sure we had an evening meeting. I'm glad to hear it was well attended, but that's something we need to keep in mind, that when we do daytime meetings such as the noontime one, you have a significant portion of the membership that wouldn't be able to participate. So it's the diversity in times is very, very important. Thank you.
All right. Thanks, Tim. Okay, take it away.
If I could just make one last comment before we move on from this. First of all, this was an all hands on deck effort. This dominated our team's work for a good chunk of time to make sure that we pulled it off really flawlessly. So if it's okay, I just want to take 15 seconds and just acknowledge by name the staff who helped make this happen. Emily Williams, Denise Donnelly, Paul Murphy, Jim Rust, Andrew Stern, Cameron McBean, Nick Vogler, Mike Berry, Linnea Walsh, Janine Hines, Maureen Quinn, and Mark Tuttle. So thank you all for doing that. As you noted, Madam Chair, this is a platform that we are already thinking through how we can leverage it for other types of engagement beyond just our public listening sessions. So we're going to continue to give that some thought. And as Erica said, it was just enjoyable. It was really fun for the team, really energizing.
Mm. Yeah, good.
I just wanted to add my congratulations and my thanks to the whole GIC team, because I went to every session, and I will say that everyone, I mean, there were certain questions, because there was, as Erica mentioned, a lot of questions regarding Medicare, and there were certain areas that people were really interested in. And every one of, GIC staff, you, Paul Murphy, Denise Donnelly, Cameron McBean, everyone is so knowledgeable, and they stepped right up, were able to answer like every single question, no matter how far out of the box they were. Really kudos to everyone. It was terrific. So I just wanted to say thank you, for listening to the members and to all of us who have, particularly Tim and myself over the years who have commented on these. Thank you so much. It was great.
Yeah, no, thanks, Bobby. Hey, Rebecca, I see you have your hand up. The floor is yours.
Thank you, Madam Chair. I just also wanted to say that the session I attended the Tuesday evening, the team did a fantastic job. And I also thought that Matt did a really nice job. Some of the people were obviously fearful about changes and that sort of thing. And I thought Matt has a really nice tone that makes everybody feel more comfortable. And it definitely made the sessions calm and enjoyable for everybody. So I appreciated that. And I was really surprised at the level of technical skill of the team answering some difficult questions.
Yeah, no, we're very fortunate to have such a dedicated staff. And, I'm thrilled to have a chance to see it on display and for, people like you, Rebecca and Bobby and others to recognize it. So thank you. All right. Go ahead.
Let's move on to the next slide. So here we're going to revisit the out-of-pocket report. As I noted at the outset, Margaret's going to back up a little bit to kind of cover again the portion that I think we may have started to feel rushed based on our agenda. So I wanted to make sure that we did that as well. So with no further ado, Margaret.
Thanks, Matt. We could move to slide 33, please. All right, thanks. I'd like to start where we left off, which I believe was discussing the highest out-of-pocket spend. In this case, it's high out-of-pocket spending is defined as $10,000 or more for a household. I want to recap a couple of important definitions in our plans. We have a out-of-pocket cap for family plans at $10,000. So that's the reason I'm focusing on this number. It's a lot of money for anyone, but $10,000 is the number where our family plans are not supposed to be exposed to additional out-of-pocket costs. However, there is a caveat. Those are costs in network and within the plan parameters. And so what we've seen here in all of these households, I requested a review from the carriers as well as from the pharmaceutical benefit managers to review why these households were above the 10,000 out-of-pocket cap, and without fail, it was due to people, 44% of it on the pharmacy side was due to people being out of the terms of the plan. So picking up their prescriptions someplace that is not, authorized. However, we also believe in these cases that the members had outside assistance with copays, such as one we believe is a TRICARE member, and so the benefit was covered through the VA. There are a number of ways there can be some coordination of benefits where the members are not actually exposed to those additional high out-of-pocket costs. So that's what we saw on the pharmacy side. On the medical side, what we saw was people who are elected plans that are narrow networks, visiting facilities that are not in their network. So that's to recap. And I wanted to start here, excuse me, and open this up again for some conversation. You have questions about these drivers or members here?
So I wanted to comment on this. 100% of households where, who were sort of contacted, but only one member engaged. So it seems to me we need to do a lot more work or figure out a way to reach people because obviously people are not responding. That's problematic. Does it mean they would more likely respond if their provider contacted them, and as opposed to the health plan? right? Because they may feel like it's not your business.
I think that's right, Commissioner Kaplan. It is very difficult for the health plans to successfully engage members in their management programs. And, I think it is a matter of feeling like your provider is your partner in your healthcare, whereas feeling that perhaps the insurance plan is just the payment mechanism, the intermediary there. We see this year over year with our engagement numbers.
Yeah.
Margaret, if I may, Commissioner Kaplan, I just want to remind the commission that given that 44% of the high out-of-pocket households are attributable to pharmacy out-of-pocket costs, we know that most of those members are using either coupons and therefore aren't actually paying those out-of-pocket costs, or they are covered by TRICARE as veterans. So it's not that every one of those households actually paid that amount, and we don't have access to that data. I just wanted to clarify that.
Thank you, Denise.
Yeah.
Still,
I don't
still,
see.
if I could just say, it's, what are we able to do about that? How do we reframe that, or reach out in a different way, or if you're looking at the narrow networks, for instance, where a lot of people select a narrow network, usually because of costs, right? But then run into difficulty later when they need the medical care. What are your thoughts? What do we do about that? It's because many people select plans that probably really aren't good for them, right? In the long run. And so, what impact can we have where, and I'm very curious how that falls into sort of race and ethnicity data. What are we looking at, and what is the composition of that, and do we even know? And how could we collect that data?
I think on the race ethnicity point, as you're aware, we are in the middle of bringing that data in. And as for the current members who are above the cap, I don't know. I don't have any way of knowing race ethnicity. Yeah. An important question, and certainly one I look forward to being able to answer.
The challenges of understanding the trends when someone goes outside of their plan. So for instance, if they're in a closed network plan and they go to an out-of-network provider, because it falls outside of the plan, it's hard for us to know a whole lot about why that is happening, right? We just don't have a window on it in many cases. One of the things that I want to understand in more detail, and which I think, Bobby, is a lot of what you're asking about, is in what circumstances and why are our members accessing care outside of the four corners of their benefit? Because it says something about the benefit, and whether that's a network or other impacts, but it reflects something about the benefits that we need to understand, the challenges that I note notwithstanding. So this is something I want us to spend some time to understand better.
It's actually a great transition to the next slide, if there aren't any more questions here.
So I do have two questions here, Margaret. One is from Toby, and then one is from Patty.
Please.
I'll jump in, I guess. Thank you very much, Margaret, for the data. This is a situation where I'm a little bit of history. I think I'm becoming one of the longest serving members of the commission. But we used to get no data, or we used to be kind of the closely guarded secrets of what was the out of pocket. And now kind of this is the second year in a row we've gotten great data. And I think it's time to kind of move from where Bobby, from getting that data, which is great, and then the insights that you've surrounded it with, and start to move to very concrete recommendations of what to do. And you know, every year we see the you arrive at the 2 years we've seen it is you arrive at the conclusion that on the medical side it's high out of plan facilities costs. I think there's been in the past there's been some comments around it's really related to substance abuse and out of plan facilities. Well, maybe we can address that in some way and create more in-plan facilities. Maybe we make the out-of-plan facilities in-plan facilities or something like that. I think we need to move to recommendations and action because this is great data and keep it coming, keep the insights coming. But I think we're kind of in the fortunate position that we're ready to kind of, at least I'm ready to get into, you know, what do we do and, you know, and see if it works.
Great, Toby. Thank you. And then Patty?
Yeah, I just wanted to thank Commissioner Kaplan for her comment, because that was exactly where my mind was going on the heels of our earlier discussion of those 79 households to collect the race and ethnicity data. For me, seems really important, and similarly, Commissioner Choate's comments about, you know, turning our findings and learnings here into something actionable, so that, you know, when we're going out to reprocure and create a benefit plan design, we're taking a look at access issues that we can see exist and sort of structuring our request around better access for the services, because, you know, it just seems like this is clearly a need that comes up year in and year out, and we should, you know, do our best as a commission to try to improve that number. So thank you.
And no, thanks, Patty, for that support. All right. I think I don't see any other questions, so we can keep moving on, or.
Sure. Next slide, please. So this graph shows diagnoses of those with out-of-pocket spend over $10,000. And this is not going to surprise Commissioner Choate or Commissioner Kaplan. In the red, that's the out-of-network costs. And, you know, once again, alcohol and drugs, that is a hugely out-of-network service. As we know, in Massachusetts broadly, nationally even, but in Massachusetts, there is a substantial access problem, both for substance use disorder treatment and, you know, and for alcohol specifically. So I think this is part of a larger Massachusetts initiative that we are aligning with our Health and Human Services Department. I know we're going to come back to you in a couple of months at a commission meeting to talk about behavioral health strategy, but it's clear that our members are, you know, are not able to access the services they need in network, and that is a problem to be solved for, both in the next procurement and at a policy level with the other state agencies. Any questions specific to this slide?
Thank you, Margaret.
Okay, let's move to the next slide. Type of service breakdown. Again, no surprises here. We see a lot of inpatient hospital, out of network, which can be substance use disorder treatment, or just going out of a narrow network. So again, this kind of lines up with what we already know and need to solve for.
Okay, keep going, Margaret. Let's hold questions and let Margaret go through the presentation, and then we'll do questions afterwards, just to be efficient and also respectful of Margaret's presentation.
Thank you. So next slide, please. I'm going to drill down a bit more into behavioral health, and with the next slide, great, perfect. This is right where we should be. We are not looking at the high out-of-pocket segment. We are looking at the behavioral health full membership. So here we also see an ample amount of red, indicating a lot of out-of-network services. I attribute this again to the access challenges in finding available therapists. This is roughly comparable to 2019's out-of-network utilization as well. Again, I'd note the proportion of out-of-pocket spending on alcohol-related treatment and substance use-related treatment. And, same comment, this is a market-wide problem, but we do have a piece of that market, and a piece of that is in our network design too. And really, it's incumbent upon us to build a strategy that gets the care in network to our members that they need. Next slide, please. And now I want to drill down a little bit more into pharmacy, because as you saw as a recurring theme, that's a major driver of out-of-pocket spending. What we have in this slide is a graph that illustrates not only the out-of-pocket amount that membership paid for therapeutic class of drugs, that's the left side, the absolute dollar amount, but also the proportion of the total cost of the drug that a member pays in out-of-pocket, the proportion. So that's the right side of the graph. There is good news in this graph. If we look at diabetic therapy over on the left, this is a really expensive treatment course. And what we see with that red dot being low on the graph as a percentage, it means that most of these medications are covered by the health plan. So then if we look at another example, we see a red dot high above thyroid preps, indicating that our members are spending a large portion of the total cost on the out-of-pocket. I'm not particularly concerned about this because in absolute dollars, if a generic thyroid drug costs $5 for a script and a member is paying 80% of that, that's $4. That's relatively low on an absolute scale. So what we're doing is we are protecting our members from the highest total cost drugs. And that, I think, again, is what the function of insurance is, and we're doing well by that measure. Now I'm happy to take questions.
I don't see any. You must have answered everybody's questions.
I just want to make one comment on the behavioral health slide, which is with the access challenges that Massachusetts and other states continues to face. I think it tees up very nicely the plan design change that we'll be voting on momentarily to provide greater access through the no cost in-network telehealth visits for behavioral health. There was also a article in State House News yesterday about a meeting that the Health Policy Commission had about utilization of behavioral health services generally during COVID. There is some really good news there, particularly as it relates to behavioral health, where telehealth will is predominantly being delivered by telehealth. Also some troubling trends in there. 1 in 4 pediatric patients actually discontinued their psychotherapy during COVID-19. So a real mixed bag as so many of these COVID telehealth related issues represent. But I just wanted to add that.
All right, great. Yeah, you can move on, Matt. Thank you for presenting this. I think everyone had some really good comments, and looks like the consistency of the data being presented out of pocket is helpful to inform our thinking for upcoming procurements. So thanks for the ongoing discussion.
Thank you, Madam Chair. The last item on our agenda, which has us pretty much on target with our agenda and timing on the agenda, is the final vote, brief presentation and final vote on FY22 plan design. So I'll turn it over to Denise Donnelly to lead this part.
Thank you, Matt. Next slide, please. So as we discussed at the last meeting, the GIC staff has proposed one plan design change for the upcoming fiscal year, and that is to provide 3 no-cost behavioral health telehealth visits in network per member per year. Current copay varies by plan. On average, it's about $15, but this is a way that we see to help continue the trend that we've seen during the COVID pandemic of members accessing behavioral health care through telehealth, and to support any challenges members may have with respect to access. We have not recommended any changes to current plan designs that would increase cost sharing for members. So that's the proposed change. Any questions? If not, I think we can move on to the vote.
Hey, so do we have any discussion, any questions, as Denise said? Otherwise, I will entertain a motion to approve. Oh, let's see, I should get it right. To accept the recommendation to modify the non-Medicare plan benefits to provide 3 no-cost in-network behavioral health televisits per member per year. Do I have a motion?
So moved.
So I heard Bobby and then Christy. So I will turn it over to our general counsel to do a roll call. For me,
Thank you, Madam
Andrew,
Chair.
I'm a yay.
Vice Chair Kaplan,
Yay.
Designee Rodell,
Yay.
Designee Butler,
Yay.
Commissioner Chavez,
Yes.
thank you. Commissioner Chapdelaine,
Aye.
Commissioner Choate,
Yes.
Commissioner Clenari,
Aye.
Commissioner Davis,
Yes.
Commissioner Garon,
Yes, I was on mute.
thank you. Commissioner Edmonds,
Yes.
Commissioner Gentile,
Yes.
Commissioner Jennings,
Yes.
Commissioner Murphy Rodriguez,
Yes.
Commissioner Sinenko,
Yes.
and Commissioner Sullivan.
Yes.
The vote passes unanimously.
Well, thank you. And I want to thank the staff for putting a spotlight on mental health. I think many of you know that this is deeply important to me, and making sure that we as a commission are supporting mental health. I do appreciate this increase in benefit. So thank you.
On that note, Madam Chair, before we close, I want to flag for commissioners and those listening that there will be an announcement coming out of the Executive Office of Health and Human Services within the next few weeks, laying out a behavioral health roadmap. This is the product of several years worth of work by the team at EOHHS. We have been in touch with leadership there as they've been working on this roadmap. We actually have time scheduled with them a little bit later on this month to review the roadmap and identify very specific opportunities that we have at the GIC to align with the roadmap and kind of bring our purchasing power and to bear to help move that agenda along. So much more to come on the behavioral health front.
Thank you, Matt. Well, I will definitely look forward to seeing more. So let's move to other business.
This is just some reminders to commissioners about meeting schedules. We'll continue to be offering them virtual as we have for the time being. Not much more to say than that on other business.
Okay, so our next meeting is March 4th. I will look forward to seeing all of you then. And unless there's any other comments or discussions or agenda items to revisit, I do believe this meeting is adjourned. But because we have a little more time, I will make sure I don't see any hands up.
I just wanted to say it was a terrific meeting. It was really, really good discussions about a variety of items. I'm very pleased about that. It was terrific. I look forward to more of those.
Thank you, Bob.
Thank you very much, Madam Chair, and thank you very much, Matt. I appreciate it. And I also appreciate the direction that the commission is taking, because it's very nice to see. As Toby mentioned earlier, we did not receive a lot of information previously, and so it's really terrific, and it spurs discussion. It's terrific to see data and to be able to discuss it and try to figure out solutions. So I think that's great.
Good. No,
So
Bobby,
thank you.
well said. Thank you, Bobby. And thank you to all commissioners. I am very grateful to an engaged and educated commission staff, as well as the board. So I feel very fortunate. And Bobby, you said it really well, so I won't repeat what you said, but I concur. And so seeing no more comments, there's the power vested in me as a virtual meeting that I can adjourn this meeting without a roll call. So thank you. We are adjourned. We'll see you in March. And happy Valentine's Day. There's no reason why we can't put a little bit of love into our work every day, right? So please do that. Okay. All right. We're adjourned. Bye-bye.
Thank you all.
Bye,
Bye, everyone.
Bye. Stay safe.